Hello, and welcome to the University of Kentucky Department of Anesthesia YouTube channel. My name is John Green. I'm a pediatric anesthesiologist, and I'm also one of the associate program directors for the residency program here. This lecture is part of our series reviewing some of the frequently missed keywords from the ABA Basic Exam in 2025, and this lecture will be talking about anatomy and airway keywords. The keywords that we're specifically going to be reviewing are the intercostal nerve anatomy, airway anatomy predictors, contraindications and complications of video laryngoscopy, and then finally we'll discuss some of the ventilation techniques for surgical airways. So we'll start with intercostal nerve anatomy. And a reminder that intercostal nerves are the ventral rami of the thoracic T1 to T12 nerves. They carry both motor and sensory fibers, and they pierce the posterior intercostal membrane about 3 centimeters distal to the intervertebral foramen, and they travel parallel to the rib in the subcostal groove between the innermost and internal intercostal muscles. As a reminder, these nerves travel along with both the intercostal artery and vein. Just anterior to the mid-axillary line, the nerve will give off a lateral cutaneous branch. This branch pierces the internal and external intercostal muscles, and it will divide into an anterior and a posterior branch. And this supplies the muscle and skin of the lateral torso. Now, the anterior cutaneous branch will continue on, and at the level of T2 to T6, it pierces the external intercostal and pectoralis major muscles, supplying the skin of the anterior thorax with smaller branches, supplying intercostal muscles and parietal pleura. At the level of T7 to T12, the anterior cutaneous branch will pierce the posterior rectus sheath, and this supplies the rectus muscles and skin of anterior abdominal wall. And then finally, there are some final branches at the level of T7 to T12 that continue on to supply the parietal peritoneum of the abdominal wall, becoming superficial at the linea alba. There are some notable exceptions. So T1 has no anterior branch, usually no lateral branch, and most of the fibers join with C8, while the remaining fibers innervate the intercostal muscles. A reminder that T2 and T3, some of the fibers give rise to the intercostal brachial nerve, which supplies the axilla and upper arm. And then T12 is technically a subcostal nerve because it's not between two ribs. Also, the lateral branch does not divide into an anterior and posterior portion, and most of this joins L1, where it forms the iliohypogastric, ilioinguinal, and or the genitofemoral nerves. So now we'll move on to airway anatomy predictors, and what we are talking about is predictors for mask ventilation, laryngoscopy, supraglottic airway placement, as well as surgical airway access. So we'll start with difficult mask ventilation. You can see the first 5 that we have listed here can be remembered by the mnemonic obese. O stands for obese, specifically an increased neck circumference. B stands for beard, or basically any facial feature that will prevent an adequate mask seal. The first E stands for elderly, specifically age 55 years old or greater. S stands for snoring, which is indicative of obstructive sleep apnea, and then the final E stands for edentulous. Some other predictors for difficult mask ventilation include being a male, having limited jaw protrusion, a high Mallampati score such as 3 or 4, and then previous neck irradiation. There's quite a few predictors for difficult laryngoscopy and or intubation. Some of the ones that we'll discuss, first and foremost, a history of difficult intubation, Again, inadequate mandibular protrusion, specifically an upper lip bite test, class 3. Limited mouth opening, such as an interincisor gap that is less than 3 centimeters. The presence of a high arched or long narrow palate. Again, a high Mallampati score, 3 or 4. Thyromental distance less than 6 centimeters. Limited neck mobility with an atlantoaxial extension less than 30 degrees. Sternomental distance less than 12 centimeters. The presence of decreased submental compliance, so if you feel it underneath your chin and it's very hard and fixed. And then finally, a neck circumference greater than 40 centimeters. All of these are predictors for difficult laryngoscopy and or intubation. Some airway anatomy predictors of difficult supraglottic airway placement. You can see that the first 4 can be remembered by the mnemonic RODS, where R stands for reduced mouth opening, O stands for obstruction, a tumor, edema, anything like that. D stands for a disrupted or a distorted airway, and S stands for stiff lungs, such as COPD, or stiff spine, which would include neck radiation. Some other predictors are obesity, edentullousness, or poor dentition. And then finally, predictors for difficult surgical airway access can be remembered by the mnemonic SHORT, where S stands for previous neck surgery, H stands for hematoma at the site, O is for obesity, R stands again for previous neck radiation, and then T stands for tumor at the site. Moving on to video laryngoscopy, we'll start with contraindications. The absolute contraindications for video laryngoscopy include severely restricted mouth opening and complete upper airway obstruction, essentially anything that will prevent adequate placement of the laryngoscope. And then relative contraindications include blood or emesis in the oropharynx. Video laryngoscopy may not be the best tool for this because once those secretions soil the camera lens, it's very difficult to see. Consciousness and or an intact gag reflex. And then finally, foreign body removal. With foreign body removal, video laryngoscopy may not be the best tool, primarily due to the ergonomics of trying to remove the foreign body. Video laryngoscopy complications, thankfully, are relatively few, but not insignificant. The first of these, oropharyngeal trauma, can be quite significant. This can include palatal perforation, an arch tear injury, a tonsillar pillar injury. And these injuries usually occur when whoever is performing the procedure is focusing on the video screen rather than looking at the mouth while they're placing the laryngoscope in the endotracheal tube. So when you place these devices, your attention should be focused on the mouth, and then once you safely place into the oropharynx, then you can swivel your attention to the video screen and proceed from there. Other complications include dental trauma, vomiting and aspiration, and then finally hypoxia. Hypoxia because we know that video laryngoscopy increases the chances of successful intubation. However, we also know that it technically does take longer than direct laryngoscopy. And so this increased time can contribute to hypoxia while you're placing the tube. So finally, we'll talk about ventilation techniques for surgical airways. If you have a tracheostomy or a cricothyrotomy, ventilation with positive pressure ventilation should be fairly similar to that with a regular endotracheal tube, assuming that you have the appropriate tube size and with all due consideration given to the underlying respiratory physiology and pathology of the patient. Some additional considerations include the potential for dislodgement or malposition, either actually coming out of the trachea or being pushed further and providing like an endobronchial mainstem situation. The potential for bleeding, especially if it's a freshly placed airway. The potential for additional injuries related to access. So if while placing the airway they accidentally caused a pneumothorax or a tracheal perforation or something like that. And then finally, a reminder that cricothyrotomy is a temporary solution and should be converted to tracheostomy within 72 hours. Now, if access was obtained with a needle or cannula, you can do low pressure ventilation or high pressure ventilation. It should be pointed out that low pressure ventilation only provides oxygenation. It does not allow for ventilation, whereas high pressure ventilation can effectively oxygenate and ventilate. Barotrauma is a significant potential complication with either of these techniques, especially with high pressure ventilation, and you must ensure adequate exhalation of gas. If the glottis is unobstructed, gas can escape through the glottis. But if the glottis is obstructed, you should consider placing a second cannula in order to facilitate adequate gas exchange. And a reminder that this is definitely a temporary airway, and a more definitive airway will need to be established as soon as possible. So with your low pressure ventilation techniques, you can do apneic oxygenation. You would just use a male Luer lock adapter at the distal end of the oxygen supply hose and connect this to the cannula. If the patient has spontaneous respirations, you can allow for spontaneous ventilation, keeping in mind that this will increase the work of breathing for the patient. So you should consider the placement of a second cannula to allow for adequate gas exchange. And then some upper airway exchange can be taking place, so you should consider using a face mask oxygenation as well. And then finally, you can use positive pressure ventilation. You can do this with either the anesthesia circuit or a resuscitation bag, keeping in mind that you will have high resistance, so you must squeeze the bag vigorously. Some of the interface options to do so, you can use either a 3 milliliter syringe with a normal 50 millimeter ET tube adapter. You can use a 10 milliliter syringe with a 7.0 ET tube, or you could just use the adapter on a pediatric size ET tube like a 3.0 ET tube. This shows the setup for a 3 milliliter syringe. So basically you would remove the plunger from the syringe, the distal end screws onto the cannula, and in the proximal end you would place a normal 50 millimeter ET tube adapter and ventilate that way. And this shows the setup if you're going to use a 10 milliliter syringe. Again, you would remove the plunger, distal end goes on the cannula, and then in the proximal end you would place a 7.0 ET tube into the barrel, inflate the cuff on the tube to provide a good seal, and then you can ventilate that way. Now, with your high pressure ventilation, if you have a formal jet ventilation interface, you can use that. The interface is connected to a 50 psi oxygen source. It ventilates at about 500 milliliters per second, so you would activate the interface for about a half to 1 second at a rate of 6 to 10 per minute. And if the glottis is obstructed, you can use a high flow stopcock at the distal end of the interface to allow for gas exchange or gas escape. If you don't have access to a jet ventilation interface, you can use the anesthesia flush valve. The anesthesia machine delivers oxygen at 10 psi when the flush valve is pressed, but it's proven to be able to ventilate at 628 milliliters per second. So with this interface, what you could use is non-compliant tubing, such as like an IV tubing. On the proximal end, you would place a 50 millimeter ET tube adapter and to connect this directly to the fresh gas flow outlet on the anesthesia machine. And in the distal end, you'd put a male Luer lock adapter and connect it to the cannula. And then hold the flush valve button for 1 second at a rate of 8 to 10 per minute. That concludes this lecture. These are the references that I've used. Thank you for watching. Have a great day.